It's a great privilege to be here. It's a really important bit of our development in terms of taking forward end-of-life care, and it's an inspired conference. Great to be here, thank you. I've got two bits of brief confession as I start. The first is I have slightly changed the title. So I incorporated in it something around service review. And the second thing is I'm definitely not an expert on this. We're on a journey of exploration at St Christopher's, and I thought I would share a bit of the sort of warts and all of our process and learning in the confidence that you won't tweet it loudly, but also that we can learn together. I think today is about sharing experience across a whole range of contexts. Antonia spoke about ensuring that the potential of Oak is seen internally, and that's really what I'm going to focus on. But before I do, I wanted to publicly thank the CSI for the opportunity it afforded St Christopher's to be part of Oak. Fliss has been a terrific lead on this and has offered huge wisdom and help as we've tried to understand the meaning of our data. And she's got some great colleagues, including Joanna, who's done a lot of the data analysis, and you'll see her work, not mine, in much of the presentation. So I incorporated service review, but what Judith asked me to talk about was how does Oak really inform business intelligence and how we work with commissioners. And for us, we've got a big question, like many hospices and palliative care organisations in this country, which is around our long-term sustainability. And I think at the heart of it is thinking about our marketing mix. Now, you don't need to worry if you don't know what that means. If you did an MBA in the 1990s, you will do. I did. And I was really disappointed. I learnt it. I loved it. I loved marketing and business planning. Anybody who's worked with me would tell you that, because I insist on doing it. But I was really disappointed. I looked up the lecturer who taught me. He was so handsome in the 1990s. He's not anymore. But then I think I've probably changed as well, so I won't focus on that. But what marketing mix is, essentially, is a relationship between what's on the left-hand side and what's on the right. And when you're thinking about how you develop your services, you need to think about who you want to reach, your customers. You need to think about what you do best and draw on that. You need to think about how you relate to the competition. And when you do that, you can start to put together a picture which is on your right, which is the kind of product that you want to deliver, the place in which it would be delivered, how you promote it, how you cost it up and price it, and your target market. And that's what I'm going to talk about in very broad terms. If you don't like this or it's confusing, just ignore it from now on. But that's the kind of framework that I'm going to focus on. And when we look at that marketing mix in relation to palliative care, there are some really, really important questions we have to ask. And they're as relevant to commissioners and people that are thinking about whole sector development as they are for individual hospices. So for us at St Christopher's, we've got to think really carefully about what is it that we really do and what specifically do we contribute to our local health economy. Are our services worth their costs, both to us and to others? How do we convey their value to commissioners and others? And most importantly, where do we allocate our resources, which, as St Luke so well described, are very finite and very difficult to obtain sometimes to achieve the very best outcomes at smallest cost to our patients and to ourselves. So they're the sort of four questions that I'm going to focus on as I talk today. And let's start with the first, which is what do we really do, and specifically what do we contribute to our local health economy? So at St Christopher's, here are some of the questions that we're thinking about now. How much of our care is truly specialist in nature? We fall back on that badge the whole time, But I know, and I think you'll know if you're a provider, some of it's specialist and some of it isn't. How do we describe that component of care that is specialist beyond structure and process? We are fantastic at talking about the inputs, the kind of very skilled staff that we have, the MDTs that we run, the regular review and so on. But how do we go beyond that to its impact? How do we translate the notion of complex problems, which is what we use when we say advise our referrers, into something more tangible? And when we think about very finite resources in South East London, how do we make sure we're getting the right people for what we can give to them? And what makes us different to others, which determines who should come to us as opposed to them? We've got a question about which aspects of our service we sell to our commissioners, and how do we differentiate between the specialist and the other components. So our commissioners think they're providing specialist care, they're purchasing specialist care from us, and they are, but they're probably purchasing a little bit else or not. And how do we have those kind of conversations with them? And in the longer term, as we look forward, do we want to separate our very specialist work and the other stuff we do into different markets? So there's some of the questions about our offerings. This is how very practically we look at the work that we do at St Christopher's. Up the y-axis you've got the complexity of need, and along the x-axis you've got our reach. And we've got a range of care and support, and I'm going to show you that in a moment. We've got education, training, and we've got research and evaluation as smaller components of our contribution either to the local health economy or a bit further afield. And don't worry too much about the detail, but I tried to show you here something around the triangle of care and support and how that's differentiated depending on complexity and reach. And right at the top, this isn't proportional in how it's written, but right at the top you can see our specialist palliative care, but you can see a whole variety of services underneath. And they've all got a role, we think, in what we contribute to the local health economy, but how indeed do we decide who is where, and what bits do we sell, and what bits do we develop and report on. The next question is about are our services worth their costs, both to us and to others? And our starting point is we know we're expensive and our reach in our population is limited. So St Christopher's costs about £19 million a year to run. 30% of that comes from statutory sources. We're no different to most other hospices in the country. We spend just under £4 million generating voluntary funding. That is an extraordinary amount of money. And our community makes a huge contribution, about £32,000 a day. We are not cheap, and we have to be value to all of those people who are putting in the effort that I describe in that. This is just another brief way of showing it, but I think this is actually a really helpful slide, and hospices should do more of this. But at the bottom you can see the money that we get from our local CCGs. On the red you see what we fundraise. We get a very small proportion from our shops. We have about 19 shops, bit of investment come. And then you can see the amount of money at the top that we put in to raise the funds. As we look forward as a sector as a whole, when we start in South East London to think critically about who delivers what, our services that are not funded by commissioners don't come free. We are actually using a lot of money to raise the money to deliver the care. Let's think then about the beneficiaries and the extent of our reach, and this is data from last year, and in many respects we're very happy with the growing trends. So we delivered care to just under 3,500 patients, about 1,200 adults who had bereavement support, about 500 carers, about 450 children and families who get care from a specialist bereavement service, and about 400 people who get care from a personal care service. But when you look at the total number of deaths in the area, which are 9,600, and even if you take away those deaths that you might arguably argue we shouldn't have any part in it, we're still only reaching a relatively small proportion. And we'd be no different to other hospices. I know some other hospices reach higher proportions, but generally our reach is not anywhere near the population who could benefit from us. We're expensive. This is very conservative, these costs. They don't include our overheads, but just for our staff, it's about £360 a day for a bed. It's about £150 a week for community palliative care, about £100 per attendance in our anniversary centre. And we've got to justify that. So how do we do that? Then there's the question about how we convey the value of what we do to our commissioners. And I think our starting point is we want to change our relationship with our commissioners. A lot of our contracts have got currencies that are hugely historic. We're being asked to report on number of bed days. We're even being asked to report on stuff that's outside our control. For example, the number of referrals we get for our community palliative care input. It's hardly a contractual arrangement that encourages us both to try and do differently and better in our local community. We report on all our services, despite only getting support for about 30% of our costs. We never consider our performance in relation to our population needs, only what we did last year and the year before that. Often, the quality improvements that we get through our sequins are very much at odds with what we think our priorities could be. And last year, we made a decision not to work towards a sequin, and the commissioners were surprised, and we had mixed feelings, but it was so different to what we thought we should be focusing our effort on that we thought it was worth losing the money. And most importantly, we're really concerned that if we use our money differently, that we think will give better care to people, will we actually be penalised contractually? Now that is a crazy situation, crazy for the commissioners and crazy for us. So I'm going to argue in a moment that actually Oak and Outcomes helps us with that. This is where we want to go with our commissioners. We want a co-commissioning relationship. We want them to recognise that for every pound that they're putting in, we're also putting in a couple of pounds, and so is our community. And if we could begin from there, we could actually start to have some really meaningful conversations about what we all focus on and where we put our resources. We'd like to focus on the needs of our shared population. They've got a population perspective and we have, but we just don't talk that language together. So could we do that more? Could we drive together towards better outcomes for our beneficiaries? We certainly think we could if we had the language and the data and the tools, and that's what I'm going to argue Oak will offer us. And I think that if we could reflect those kind of outcome measures in our currencies of our contract and any sequence, then we'd all be running in the same direction instead of, and I'd say this as much for the commissioners as us, a shared frustration about the quality of the relationship and the conversations. The other question is, where do we best allocate our resources to achieve best outcomes at smallest cost? And 19 million is a lot of money to raise every year, but most importantly, we have a responsibility to use it really responsibly. And I think at the moment, very often, we're not entirely clear where to put it for maximum impact. We at St Christopher's, like many other hospices in the country, got a very broad range of services. We look after people in the community, we look after people in the inpatient unit, we've got outpatient services, drop-in and self-help services, we've got a personal care team, and we've got a coordination centre. And the questions I've got as a manager is, how similar or different are the needs of those people that use those different services? Is it just referrer behaviour that really shapes which service they come into? And is there something about where you come in, you stay, as opposed to moving between services depending on what your needs are? Do the similar services, we've got 3 palliative care teams serving different boroughs. Our population is about 1.5 million. We've got 3 community palliative care teams. Do those same services produce the same outcomes? Or have they got different processes, different populations, and do they have a different level of impact? And when patients are transferred between services or a new service becomes available for somebody, do their outcomes improve? So there's some of the questions that we really have to ask to make sure that the right people are in the right service and that actually people are benefiting at the lowest cost possible. So how can outcome measures help us with these dilemmas? And here's the oak tree, and here's my marketing mix. And I'm going to just talk briefly now about those 4 Ps and how we've used oak data around them. So I've drawn from 2 sets of oak data. We started work really on oak in early 2015, and last year we reported on about 850 patients, and we've had a recent fantastic data set reported on which had about 2,500 patients in it, and I'm going to draw from both of those sources now. At St Christopher's, we're measuring phase of illness. We're measuring functionality through the AKPS described by Judith. We use IPOS, and we haven't started work, but our intention is to use Bartel a bit more. We do it a little bit to introduce Zarit, which is around carer experience and burden, and we do collect on views on care. And views on care used to be part of the SKIP measure. Does anybody remember SKIP? And I think that SKIP was set up by St Christopher's. It was another outcome measure, and it's a good example of maturity and generosity when that parts of that got integrated into IPOS, which enabled the hospice sector not to feel it had to choose between 2, but to draw on one that was much stronger and validated in the work that Fliss and her team had done. So let's start with the first P, which is about product, and I'm thinking specifically about the severity of problems that we see and considering other problems that we need to address in our work as specialist palliative care providers. Here is some very early data. You can see along the x-axis a variety of community services that run from St Christopher's, and you can see the severity of symptoms and specifically pain scored at 3 or 4 according to the different services. And the conclusion, just you don't need to worry about the detail, but the conclusion is that all the teams here have got patients with severe or overwhelming pain, regardless of variations in phase and functional status. And so that is reassuring for me that actually a lot of the people that are coming through do have severity of need that warrants the kind of expertise that we're investing a lot of resource in. This is another similar slide which talks about shortness of breath scores, this time grouped by phase of illness. And I think what's really interesting from this is that severe or overwhelming breathlessness occurs across all the phases, and that actually it continues to be a problem regardless of whether you're stable, unstable, and dying. Now, for us, when we talk to commissioners, for example, we rarely talk about shortness of breath. Our stories are usually of people's pain or distress, and I think this was a surprise to us. But it helps you recalibrate what complexity is and where we should focus some of our efforts and our learning in terms of skills. This is an interesting slide. This shows phase of illness by phase number within spells. And what I really wanted to show you is that people change phases significantly within a spell. So part of the complexity that we have, part of what people are paying for when they buy services from St Christopher's is about the rapidly changing nature of people's disease and experience and problems. And you can see how people similarly move from a period of huge instability to much greater stability or deterioration, all in one single spell. And that would be very common for physicians and others in the area, but it's something about describing what we do. So that's our product. And very finally, here's something about people's functionality. And the reason why I show this is that very often we are looking after people who have much reduced functionality. And there's our justification, or the beginning of our thinking about how actually it's not all about skilled palliative care. A lot of it is about very good nursing care or support that enables people to survive with decreasing functionality, often very quickly. Let's move on to the next P, which is about place of care, ensuring people are in the right service to meet their needs, and considering how their condition changes in the course of a spell of care and what implications this has for where they go next. So you can see here, similar slide to what I showed you earlier. In terms of phase of illness, in first phase, you can see that many more of our inpatients are unstable. That's what you'd expect. That's a good indication that the people who are coming into our inpatient unit need the resources that sit there as opposed to being in the community. And if you looked at a slide that shows our outpatients, those outpatients are even more stable than our community palliative care patients. That's right. Now that's not consistent over our community palliative care teams. And that might be something about referral behaviour in the different areas. It may also be something about how tolerant people are in community palliative care teams about having unstable patients in that context. I don't know the answer to that. And if you look here at phase of illness across teams, some of those are, so the top one is a care coordination service, and you would expect to see less unstable people there than you would in some of our community palliative care teams that have got much more specialist and multidisciplinary input. And if you look at what we call CAT and CCT, they're our outpatient providers. So they're the people that do the outpatient services for us. And so you can see that the teams that are multidisciplinary and highly mobile are actually looking after a lot of very unstable people. Again, just interesting to look at functionality, and again, if you look at CAT and CCT, there are outpatient services. People's functionality is much higher, and that's what you'd expect. You wouldn't want people with very poor functionality having to drag themselves into an outpatient clinic. Equally, when I worked in community palliative care, I went to see everybody at home, and I remember visiting somebody who actually got into his car when I left to go out for a trip, and I remember thinking, it's a bit odd, but that's just the way it was. What poor use of services. I actually, when I did my PhD and I was studying people in daycare, there were people being brought into daycare by drivers, and then they were driving themselves to the vet afterwards with their dog. And I remember then thinking, aha, something is not quite right here. If you look at our symptom burden across teams, this is really, really interesting. And again, this is where you can start to see where you put the emphasis of your highly skilled staff in relation to symptom burden. And BCC, for example, which is on the left-hand side, is a nurse-led service. People come into that deemed to be in the last year of life. They don't have to be symptomatic. They don't have to have complex needs. In fact, they do have a number of significant symptoms, but nothing like, for example, the teams that you would see on the right-hand side, which is our specialist palliative care services. Let's think about the next P, which is about the price. And I really like this data. So these are patient outcomes, people who had moderate, severe or overwhelming symptoms or problems at the start of the phase, and how had they improved by the end of the phase. And this is data from the community, and you can see significant improvement in many of the symptoms from the start to the finish. And this is really important if we need to justify what we're actually doing. And of course, that's when you're receiving people who've got severe problems and you want to address them. But I also really like this. This is about well-being. So this is about anticipatory care, and this is about people who came with absent or mild problems at the start of the phase, which hadn't worsened by the end of the phase. And that is also success. We don't tend to measure it very much, but you can see here that for many of our patients that were captured in this data, they continued to have good quality of life and hadn't deteriorated by the end of phase. Very important to collect as well, particularly as we think about health promoting palliative care and public health approaches and so on. Last P, about promoting our services and explaining to commissioners and others the difference that we can make, and thinking about our value in the wider health economy. So these two slides are my favourite. And the reason that I like them is you need to see both in combination. The first talks about a change in dependency, and it shows that actually many people are getting worse in terms of their dependency scores rather than better. But when you look at the same population in relation to their symptom scores, many have got improving quality of life and reduced symptom burden, despite the loss of functionality and increased dependency. And that, for us in palliative care, is the nub of the issue. That's what we have to contend with. And very often when we talk about quality of life, people forget that we're working against nature, which is making it harder and harder. So, final thoughts then. At St Christopher's, we're just starting to see the potential of outcome data to inform our business processes. We really are at the beginning of the journey, and I'd love to repeat this in a year's time and to have really done some more thinking and done some more conversations with our commissioners. We met them 2 weeks ago. We had an afternoon where we got together with Trinity Hospice in West London. We brought all our commissioners together for South London, and we said to them that we wanted to start moving towards more of an outcomes-based discussion and a more population-based focus in relation to outcomes. And they were very, very open to it. It was a really interesting and happy afternoon. And my hope is now, as we begin to plan in 2017, we renew a 3-year contract with our commissioners, and we have 5 commissioners. They work in a consortium. And my hope is that for the first time, we will be talking about currencies that are meaningful to both. We will be talking about improvements that we both aspire to that are based on OAK measures, and that we will start to see some quality improvements that both groups believe are important, either for individuals or for the population as a whole. We've got significant challenges around the completeness of our data, and that's an ongoing struggle. And I would agree with you entirely. It isn't just for clinicians. It has to be an organisation-wide initiative. Our clinicians are really overburdened. This data is just about the last thing they need added to their list, and unless they have really strong IT support, unless they're given time and help at managerial and executive levels, it's almost impossible. But the more complete the data is, the better it is for really thinking critically about some of the questions that we must face around what do we continue doing, what do we stop doing, what do we do more of, and what do we do quite differently. Our non-clinical staff become more interested in this, but you have to keep having the conversations. And we very recently had a seminar which Joanna from CSI came and spoke at, and it was the first time, I think, where clinicians, fundraisers and others had all sat in the room together. It was a great meeting, and I think when Fliss came to talk to our board, it was the first time that our board were interested beyond experience in outcomes. So those kind of conversations are not to be underestimated. And I think we will invest really significantly in this work to ensure we are using it to maximum effect. We're just at the beginning, but I think it's probably the single most important thing I'll introduce at St Christopher's in my time there. Thank you.
Hi, it's Penny Fansort from Isabel Hospice in Welwyn City. I just wondered actually how you collected your data, whether you did it all manually or whether you have electronic system.
So we use Infoflex as our EPR. We've got scars from that. But actually what we do is we've adapted it and we collect it on that. It is a real challenge downloading it, exporting it, cleansing it, and then reproducing it. And at the moment, CSI have been hugely helpful to us. They're now withdrawing from the very practical stuff that we must do, and we are now putting lots more resource into the kind of infrastructure that we need around that. We have also invested in a software package which is designed to enable easy collection, but it's the conversation between Infoflex and this other package that inhibits its use. But I think the biggest difference that I have noticed in recent weeks since Joanna came and talked about data being incomplete is that people are starting to replace stuff that they used to previously record about patients with oaked style stuff. So I noticed for the first time when I walk the wards on a Monday, I always look at the boards that tell me who's in. And for the first time ever, we've now got a column that says phase. Yes! But it's, and actually people are starting to use it. So it's not, I think what I've realised is I kept thinking we were just overlaying more and more data, but actually hopefully we're stripping out a bit that we collected previously and putting in something new.
Sharon Yates, matron at Sobel House Hospice in Oxford. So a question for you both really, because the issue I have when I'm trying to explain, it's an NHS hospice, around the complexity v the dependency. So obviously they look at numbers and our numbers are pretty good. So I like the fact that you've put the dying, non-complex, complex. I think that's hugely important. But I wondered if where dependency fits in that. So about what you were saying around, patients becoming more and more dependent, whereas I can see that some of my stable palliative care patients will still be dependent, and so I just wondered whether that's something we should consider adding along with your complexity, non-complexity on dying.
Well, I think Fliss would give a better answer than me, but at a very practical level, what's fantastic is when you start bringing the two aspects together. So we do have slides that show us the sort of AKPS scores against phase, for example, or against symptom burden. And that's when you can start to see the relationships between functionality and whatever other problems that they have got.
I'm just thinking about my handover sheet. So like you, if I can start seeing phase on it, but then I'm thinking, do I have phase plus D for dependent or C for complex?
Yeah, if I just give another before we go to Fliss. So I talked about the nursing and acuity and dependency toolkit. So across all our areas, and this is work in progress, the inpatient centre probably more advanced than anywhere, but from our IPOS, from our Karnofsky, from our phase, we actually pull all that information together to actually look and determine high, medium, low complexity of our patients and their needs. So we're implementing it on a very practical basis at St Luke's, and that then determines our staffing levels across all the different areas and our response times within community.
So you've had it here first, okay? This is a first. You are all familiar with the TNN system for solid tumours. And so if an oncologist is talking about a lung cancer and he says T4, N1, M1, you all know what that means as clinicians. If you don't know what that means, it's a very easy language that you can learn. What we're working on at the moment is pulling together a system to describe complexity in palliative care. So therefore, I might ring up another service and say, I've got somebody who's in an unstable phase, a functional status of 20%, very poor, and problem severity high. And that means in that half a sentence, I have communicated very clearly complexity, what you're trying to describe, but mostly we have been used to telling a long story around that. And it just is a kind of shorthand. It doesn't replace the stories, but it's a very effective way of being able to say, this person is quite dependent, got high problems, but is in this particular state. We know that means we're going to have to do quite a bit of hands-on care for that person, but we're also going to have to put in a lot around their problem severity. We might have another person who's stable, functional status 70% and low problem severity. Okay, we know we don't have to rush out the door tomorrow to get it sorted. So it just begins to take us into a common language and a common understanding. It's a paper that we're in the process of trying to work through the best way to inform, and we've recently collected a wealth of data that will help us develop that language properly.